morning. This is Harlan Wilson, and we're going to have a conversation today about health IT innovation and sort of what you've done before and the exciting project that you got to participate in, the Beacon project. And then what I'd look forward to is learning more about sort of where you are now and what you think the future has to hold in terms of health IT innovation.
Well, I'm a family physician by training and practiced in South Bend, Indiana for nearly 30 years, and also taught in 2 residency programs, family medicine residency programs while there, and thoroughly enjoyed the practice of medicine. While I was doing that, over those years, many years, became very interested in the technology aspects, and that kind of then led to me becoming a Chief Medical Information Officer or Chief Medical Informatics Officer, CMIO, had both titles, and 2 very large organizations. First Trinity Health and then later Ascension Health most recently. So for 13 years I was able to see the progression from talking about electronic health records, for example, to actually designing and implementing them, which is a lot of fun, and getting physicians and their staff to become more digital and to not be afraid of the technology. So that was all a lot of fun, and got to see much of that. During that same time, from the early 90s on, also became very involved in the health information exchange movement, which is still struggling, to say the least. But we went through several phases. They were called CHIMs at first, and then RIOs. But health information exchange, I firmly believe in, and still involved in several of those to try to advance that effort, because I think it does help the interoperability problem that we're experiencing now across the U.S. with as we become more digital. Because what we don't want is just to create digital silos out of paper silos, right? Yeah. We've been in paper silos for decades. So we're trying hard to move that. So as a CMIO, in these large organizations, the other thing that was very exciting for me and I enjoyed throughout my career was the innovation piece. And especially within Ascension Health, I worked with a small team called the Innovation Accelerator Team. And there I was exposed to some of the technologies that were being developed, but also some of the technology that were not traditionally used in healthcare, so to speak. But we're now finding a place in healthcare, and then also the mobile technologies that came about in just the last 4 or 5 years. That brings us to the Beacon Grant. So one of my most exciting projects that I did at St. Vincent Health here in Indianapolis, which is a 22 hospital system, about 16,000 employees, $6 billion annual revenue, and one of the larger ministries within Ascension Health. So working with Ascension people and with the local people, I was able to be part of the one of the 17 communities that were awarded the Beacon Community Grant Program. And the purpose of that program, which was launched in 2010, mid-2010, the purpose was to be able to show how technology could improve healthcare services, improve the healthcare experience for patients, and also lower costs. And only 17 were selected from like 200 plus applications.
That's incredible.
And the applicant in our case was Indiana Health Information Exchange. St. Vincent Health is one of the 5 owners of Indiana Health Information Exchange, and I sit on their management board. And so they asked me at the end of 2009 when the Beacon Grant was announced, and we only had 5 weeks to submit the grant by the end of January 2010. So we had a very active team of people representing different segments and different factions within the Health Information Exchange putting this together. They recruited me to join the team because they knew that I was interested in a particular area as how we could use technology to reduce hospital readmissions. Now, at that time, very early 2010, we even knew that CMS, the federal government, as a major payer for healthcare, was in fact going to move forward with penalties for readmission rates being too high, and withholding payments for certain diagnoses that had already been talked about. So I knew that our organization, as most organizations at that time, were not prepared and were not thinking aggressively on how we could reduce these readmissions, because that was counterintuitive, right?
Yeah.
I mean, that was revenue that you were trying to get rid of. Well, nobody wanted to do that at the time, but we knew this was coming. And in fact, of course, October 1st, 2012, CMS initiated the first penalty and withholding of payment or non-payment for certain diagnoses. So it was timely. And what I wanted to be able to do was to show how we could interact with patients and engage patients in their care more actively using technology while they were at home following a discharge. So not patients in a rehab facility or nursing home, but patients going home, which is the majority. And we narrowed it to 2 diagnoses: heart failure, congestive heart failure, and COPD, chronic obstructive pulmonary disease, because at the time those 2 were the highest, the diagnoses with the highest rates of readmission. And it was around, national average was around 20-21% readmission within 30 days. So think about that. 1 out of every 5 patients was coming back in the hospital. And there are a lot of reasons for that, but a lot of them could be solved. One was medication reconciliation, just being able to get the medications and transportation to their physician's offices. So really not technical solutions needed, but we felt that one area that we could really impact was having contact with these patients on a regular basis, monitoring their vital signs at home, asking them daily questions so that if they would answer no or yes to a certain question that was not favorable, then we could do early intervention. And these were with nurses, not physicians, but with nurses that were monitoring these patients. So we did a randomized controlled trial. We used St. Vincent hospitals and about 6 other non-St. Vincent hospitals that participated in the trial. We recruited, over the course of 2 years, about 200 patients that were randomized. And we were able to show from baseline some significant reductions in those facilities, 60 to 70% reductions in those readmission rates. So that was an important endpoint. And we used the health information exchange, in fact, to be able to tell whether a patient indeed was readmitted to any facility within the central Indiana area during that 30-day window post-discharge. Now, the other endpoint that we were very interested in and pleasantly surprised was by maintaining this virtual contact with the patient for 30 days, again, by telephone, by video conferencing with the nurses, and the daily vitals, et cetera. Could we show an improvement in their activation score? So I'll explain that. So patient engagement is kind of a broad term. Patient activation is well defined as the patient's ability to understand their chronic disease and their confidence in taking care of their chronic disease themselves. So it's really focused on them, not as much their family. And there is a patient activation measure, PAM survey tool, which I bought the license for, and very well validated, been in the literature 10, 12 years, and very well validated, but mostly in face-to-face visits. So the creator of that tool, Professor Judith Hibbert, University of Oregon, now Professor Emeritus, I actually contacted her after our study was over and asked, had anyone used your instrument, your survey tool, the PAM, in a virtual environment? And the answer was no. She was not aware of that. So what we were able to show in a short 30-day window, the difference between the intervention and control group evenly matched in terms of their comorbidities and demographics, et cetera, evenly matched groups, we were able to show a statistically significant difference with a very low p-value in these 2 groups in terms of their activation. Well, that made sense. Embedded in the device that we used and put in their homes were 17 videos, and the nurse would assign videos. The nurse would then video chat also, not daily, but every few days with the patient answer their questions, make sure that they were understanding their disease process. And even though the endpoint was studying heart failure and COPD, many of the patients had multiple chronic diseases, diabetes, renal insufficiency, other maladies that they had difficulty understanding and understanding their medication regimen. Well, the nurse was going to help them with all that. But most importantly is when the patient began to falter at any point, and it could be just a subjective symptom that they answered on the question, or it could be a change in their vital signs. Their weight went up 2 pounds, for example, overnight. Then the nurse took the early intervention and would help facilitate them being seen by their providers, primary care specialists or both, and not going to the emergency room.
Incredible.
Because we knew that if they went to the emergency room, these people with chronic disease burdens, as they had, would have a 90-95% chance of being readmitted just because that's the way it is. And so we were able to reduce those readmissions significantly, and like I said, very surprisingly, even in 30 days, able to show statistically significant changes in that patient activation score, which the beauty of that is, and we don't know this, but intuitively, that has a shelf life. So even if you take away the monitoring and you take away the nurse interaction, if the patient gets to a stable level, you know that they will be able to manage their condition, their chronic condition, better.
Because you've trained them.
Because you've had that training. What we don't know, and future research would hopefully show, is when is it safe to wean the patients from the monitoring, the very close daily monitoring, because there is an expense to that, obviously. And when is it safe to do that? So a weaning protocol, if you will. Just like when we wean patients off of ventilators in the ICU, there's a protocol to follow and certain parameters that have to be met before you begin the weaning process. So that would be future research that would be interesting. And then two is, how long does the knowledge transfer last? The activation, the so-called activation. And does it also cross over to other areas of their care? And then third area, which would be great for future research, is can we likewise measure the involvement and the activation levels of the family, the caregiver? Because in most cases, the caregiver is a family member. And we know how important that is for patients with chronic disease. So fascinating study. It gave us more questions than it did answers, probably, in future research, which I would love to be part of. But it was a first of its kind in this kind of virtual environment, and being able to show that connection between the nurse and the patient can afford many opportunities besides just taking the vital signs.
Sure. Interestingly, to take that in a different direction, that I hope by the time we finish our time together today, we'll tell a fantastic story for some of the innovations that's going on today. But you're a pioneer in terms of telehealth, and what would you call this? Telemedicine, remote monitoring? What buzz would you use for that?
It has many terms, Harlan. The broadest term is probably telehealth or telemedicine. And then there's remote care, remote patient monitoring. Those are all terms that are used. Now we're seeing the term virtual care being used. It's all similar, where it means that the patient and the provider could be physician, nurse, therapist, pharmacist, they are separated by distance, and they're connected through technology.
Technology-mediated communication. So what I'm interested on, and as I say, that hopefully the story will come together as we keep talking, but very interestingly, what would you say is the future of telehealth, not just in terms of delivery, which we're seeing a great explosion that's occurring, I think, right now, but also, a big mechanism, actually, to make innovation successful, we have to have it paid for in some form or fashion. So I'm always asking the question, who's going to pay for it? Right. What's your thought in terms of where we are in telemedicine, and as crazy or as benign or not, what would happen in telemedicine, and then what do you think in terms of the business model?
Yeah. Well, I think the whole telehealth, and I'll use the broader term telehealth, area is on the cusp of an explosion. I mean, it is really moving rapidly, and this is an area now in my, as I transitioned out of the CMIO role, that I am paying very close attention to across the country. and even globally. And in some cases, the other countries like the UK are farther ahead than we are. They've been doing this longer. But to specifically answer your question about the reimbursement piece, I get asked this question all the time. Has that been a hindrance to the development of telehealth and the deployment of telehealth? And I think the answer is definitely yes. And it's because of our fee-for-service environment, which still dominates our reimbursement. As we move away from more of a fee-for-service, where that is stacked in favor of a face-to-face visit, there has to be an encounter, and then from that encounter comes a bill. All right, so there's a transaction there. And as we move away from that and being able to prove that, that the provider and the patient were together, which is kind of old-fashioned, archaic, because it doesn't, with technology, that doesn't
really matter, yeah.
It doesn't need to happen, right? They don't have to be face-to-face with each other. So as we move, and as technology allows us to have these encounters at a distance, if you will, care at a distance, the reimbursement has lagged behind. But the thing that's also happening at the same time, and fairly rapidly now, is more the fee-for-value. So the value-based payment reform, which we're starting to see pick up a lot of momentum. And of course, this is accountable care organizations and Medicare shared savings programs and a variety of things, even up to full capitation, like the Kaiser system. In those systems, this has a stronger ROI, the telehealth piece, because it's not about being reimbursed for a specific encounter. Because sometimes, and the reimbursement levels have been so low for those specific encounters, that it almost costs you as much to go after the reimbursement as what you get paid. But it really now, the focus in these value-based payment methodologies is on cost avoidance. Okay? And that's a 180-degree flip from where we have been the majority of my career, of course. And now, as we're seeing the country move fairly rapidly, I think the latest statistic I saw was like 40% of healthcare systems have contracts that have some sort of financial risk involved, some level. All right, that's going to move fairly rapidly over the next 3 to 5 years, and I think the organizations then will begin investing more in the telehealth technologies and care at a distance, because what you want to do is focus on the people who are costing you the most. If you are financially at risk for population, and it could be 500 patients or 10,000 patients or whatever that number is, that you have financial risk, Medicare, Medicaid, commercial, it doesn't matter, then you better be paying attention to those that are costing you the most. And traditionally, across populations, it's 2 to 3%, maybe 5% of any given population accounts for about 50% of the cost. And if you go up to
which goes to your point of like the CH.
Then it's like 70, 75% of your cost. So you don't have to look very far to find the people who are costing you the most. And then are there things you can do to reduce the amount of expenditures for those patients? Absolutely. And this is one tool. There are other tools too, like providing transportation to their physician visits. Something simple, but many organizations don't do.
Yeah.
But when they miss their visits, then they show up in the emergency room. So there are so many things that we can do that are not necessarily medically driven, but really that will result in a reduction, significant reduction in the cost. And we were able to show this in the Beacon grant, not just for the 30-day readmission piece. We had a second arm of that program where we had enough of the devices and we had enough of the nursing time paid for by the grant that I said, let's open up a second arm and let's just go after the sickest patients we can find. And not limited to being discharged, not limited to heart failure or COPD. Just find the sickest patients that cost the most. And we did within our St. Vincent system. And we had 134, I think, we recruited within a year. And they had tremendous costs. We had one lady with 13 admissions in 2011 and $156,000 in costs because she was on our self-insured health plan at St. Vincent. We put her in the program for most of 2012, and her cost to the same health plan was $2,500.
Oh my gosh.
$156,000 to $2,500.
Wow. Wow.
So there are,
which is it? Is it the technology-mediated communication with the caregiver, or the behavioral change in her engagement, as you say, activation?
It was both.
Okay.
Because we had been, in fact, her cardiologist called me and said, Alan, can you put her in this program? Well, we were randomizing patients at the time. I said, but we created a second arm and non-randomized patients because we wanted to find the sickest patients and just try to prove the ROI. So we did. We opened up a second arm. And he said, this patient is the only patient I have given my personal cell number to and said, please call me, don't go to emergency. Still.
Wow.
And she was labeled as non-compliant, didn't take her medications, didn't keep her doctor's appointments. All of that went away.
Wow.
Because the connection with the nurse, virtual connection. Okay, so she never physically saw this nurse. She was part of heart failure clinic and everything, had all kind of support. But because this nurse had that connection with her, virtual connection we'll call it, she had a trusted friend, trusted partner in her health care. And it changed her dramatically. She became very compliant. She took her medications. She kept all her appointments. So, I mean, that's one case. But we actually had half a dozen or more those types of cases, very high expenditures in the baseline where we had access to the information, and then extremely lower amounts, relatively speaking. I mean, we're talking 50, 60% or more. Hers was very dramatic, but even 50, 60% reduction compared to previous baseline. Well, that pays for a lot of technology, nursing time, etc. But it needs to be for specific patients that have to be identified. And this gets us into the area of analytics. Which
You bet, yes.
I
want to know all about the analytics. You know, that's a hot topic. The whole area of data and how to make the data meaningful, and you know, the movement of EMR and what's talking to who's talking to, as you mentioned, the exchanges, you know, all of that. It's a really big area that people are trying to figure out what's going to shake out. And I think you have a very good vantage point in terms of, you know, every time I listen to you, I love to hear sort of what you think is going on there, and some of your ideas in terms of how to make it actionable.